start the next session, and this is precision medicine and mucosal healing in IBD. We have a small talk by Dr. Rajendra Patel on endoscopic differential diagnosis. I think most of it has been covered, but just to summarize what we can have in the statements to be included. And this will be followed by panel discussion on mucosal healing by Dr. Ramesh. And Dr. Ramesh should request you to moderate the session. This is your session.
Good afternoon, everyone. After a very heavy discussion in the pre-lunch session, I will be briefly describing about endoscopic differential diagnosis such as IBD mimics, differentiating UC from CD and CD from TB. As you know that with the advancement of endoscopic technique and availability of newer modality and also increase in availability of procedure as such, there are multitude of lesions are being diagnosed, and there is pitfall in diagnosing IBD without considering other diagnoses. And hence differential diagnosis can include inflammatory and non-inflammatory conditions. So IBD cannot be diagnosed on endoscopy appearance alone, and as already it was discussed. So we all know the classical endoscopic appearance of Crohn's disease and ulcerative colitis. These are the highlight I have presented in the table. That Crohn's, we know it can involve any part. Ulcerative colitis mainly the colon and rectum. There are skip lesions. There are strictures or deformed IC wall and involvement of terminal ileum, and stricture, fistula and perianal disease are more common in Crohn's, whereas it is more of continuous involvement with proximal extension from the rectum. IC wall rarely involved except in patient with backwash ileitis and when it is associated with PSC. The ulcers are usually distributed circumferentially. Even if there are linear ulcers, they are circumferentially distributed. And strictures are very rare, and perianal involvement are rare. There is sometimes there is a diagnostic differentiating Crohn's colitis and ulcerative colitis is a difficult situation, especially in a flare-up situation, like when there is acute flare, when there is lot of bleeding, the ulcers are large, lot of mucosal edema is there. So some points can help us to differentiate these, like Crohn's colitis can have varying ulcers like deep, stellate, linear or serpiginous ulcer. Sometimes they can just present as multiple aphthous ulcer. Ulcerative colitis, if they have longitudinal ulcer, they are evenly distributed, not in a skip fashion. Skip lesions, cobblestoning and strictures are more in Crohn's colitis and they are absent in ulcerative colitis. Extracolonic features can sometimes help us to differentiate Crohn's colitis and ulcerative colitis. And rectum at index in the endoscopy is very important. Like rectum is always involved in UC except in few situations like pediatric UC and PSC UC. Other feature we have to consider when we differentiate UC from CD is like around 10 to 30% of UC patient, especially with PSC, can have backwash ileitis, and this has to be differentiated from Crohn's ileitis. Focally active gastritis and diffuse duodenitis can also be present in younger patients with UC. So sometimes they may not help us to differentiate these two. And we all know that all isolated terminal ileitis may not be Crohn's disease. It may be just non-specific or infective in etiology. Endoscopy with other modalities can help us to differentiate CD from UC in around 85% of the patient. One of the prospective study which followed 350 patients for over a period of 22 months showed that index colonoscopy with biopsy is important because it accurately distinguishes CD from UC in around 90% of the patient. So whenever patient comes with a second or third colonoscopy, we have to try to see the first colonoscopy if it is available. And only in 4% patient the IBD diagnosis was revised. And coming to IBD mimics, we have a long list of IBD mimics which we have to rule out before making a diagnosis of IBD, and which can include infectious and non-infectious diseases. Common one among them are the infectious colitis, especially in our country: drug-induced colitis, ischemic colitis, including vasculitis, and patient with radiation colitis. Many studies have shown that around 30% of the patient with acute bloody mucoid diarrhea, they have infective etiology as the cause. And some can present like UC, like Salmonella, Shigella, and Campylobacter. Some can look like Crohn's, especially Yersinia and CMV. And some can be superimposed over IBD. So here is a long list of infective mimics with classical endoscopic appearance. But caveat to this is when we have background of IBD, the classical endoscopic appearance might not be present. For example, when we have C. difficile, the pseudomembranes which we see in patients with C. difficile may not be evident in patient with IBD. So we may not find the classical endoscopic appearance. So hence the infective mimic would not have the classical endoscopic appearance in background of IBD. So that's why differentiating sometimes may be difficult. Superadded infection can mimic as an acute flare, and this has to be considered when patients are on biological or steroid therapy, and the common one among being has been highlighted here. So other IBD mimics in TB endemic region such as India has to be the intestinal TB, because it forms a diagnostic dilemma between Crohn's and ileocecal TB. From few studies, it has been showed that for the past 2 decades, the cases of CD misdiagnosed as ITB have been decreasing, and TB misdiagnosed as CD have been increasing. And we know that based on many studies and meta-analysis, that few features can help us to differentiate CD from TB, like left colon or rectosigmoid involvement, longitudinal ulcers, cobblestoning, strictures, or skip lesions can favor CD over TB, but they are not exclusive of each other. And we can see that many studies, they said that sometimes site may not help when usually if it is right colon or IC wall or terminal involvement, all the studies show that equal distribution of involvement in both the CD and TB. Also, only few endoscopic findings can favor one over the other, but sometimes we can find overlapping features in both of them. So, because of this diagnostic dilemma, many Bayesian like predictive models have been proposed, which calculate scores based on multiple factors, including clinical, biochemical, endoscopic, histopathological, and other modalities, which helps to predict the like sensitivity, specificity, and accuracy going more than about 90%. So endoscopy alone cannot help us to differentiate these. So multiple parametric predictive models are required. So coming to the statements, the classical endoscopic features of ulcerative colitis are continuous and confluent colonic involvement with clear demarcation of inflammation and rectal involvement. The classical endoscopic features in Crohn's are skip lesions, presence of strictures and fistula, and perianal involvement. Index ileocolonoscopy with biopsy helps to accurately differentiate CD from UC in majority of the patients. Infective and non-infective mimics of IBD have to be ruled out before confirmation of diagnosis of IBD. Differentiating ITB and CD is difficult based on endoscopic appearance and histopathology alone. Hence, multi-parametric approach and clinical monitoring and follow-up is suggested to differentiate CD from ITB. Thank you.
Thank you very much, Rajendra. You can actually keep this thing on because we are slightly well within our time. So, my question to all of you is that now we have 5 statements which have been put. Can we go ahead with all these 5 statements, or does anyone have any reservation? First, the classical endoscopic features of ulcerative colitis are continuous and confluent colonic involvement with clear demarcation of inflammation, rectal involvement. The classical endoscopic features in Crohn's are skip lesions, presence of strictures and fistula, and perianal involvement.
All these will come as introduction, no, Doctor? Come right at the beginning, endoscopic, when you're just starting. Do we need a statement? So right in the beginning, it will come as introductory. What is normal? You don't need a statement.
We don't require these.
It's a preamble. It's a preamble.
Now,
Not even to the statement, to the whole topic.
what this statements actually, the proposed statements come under which section? IBD mimics?
Differentiating IBD from other disease. So
All these are
when we are
introductory
differentiating
statements.
other mimics and all, so we should know the classical.
So
Now,
only
okay,
last
okay.
three,
Now,
only last three we need.
the question that I'm going to put to you
Last
is
three we need. Last
1, 2,
Last
and
two.
3 don't refer to IBD mimics. They are IBD.
IBD.
So they need to be taken out of this and transplanted somewhere else, much earlier, because these 3 are IBD, nothing to do with IBD mimics. What you want to highlight in this particular section is that the infective and non-infective mimics of IBD have to be ruled out before confirmation of diagnosis of IBD. So you need to be aware. Second is differentiating tuberculosis from Crohn's involves something much beyond endoscopic appearance and histopathology. That's why you're putting it as a multi-parametric approach. These 2 are okay, but the first 3 are IBD. So that will not come as statements with respect to IBD mimics. It will come as...
And
But it's not under IBD mimics. Okay, in the statement, in the beginning.
Rupa, do you need a statement saying that colonoscopy can differentiate CD from UC? Do we need a statement? Or can we put it in the discussion when you're talking about diagnosis in general? Okay. Now the 4th statement, I think, somewhere previously we've discussed about doing endoscopy to look for IBD mimics. I think, was that Usha's statement? No, the 4th, yeah, that was where we talked about timing of endoscopy and was it Vishal? Vishal, was it in your section where we discussed endoscopy to look for IBD mimics? I think this is almost similar to that. So whether that statement can be brought here.
He had not incorporated
No,
it
that's
into
okay.
his
But what I'm saying is, it was discussed there. So have a common statement.
So I think what needs to be done is this needs to be broken into 2. In answer to your question, whether we need a statement about CD versus this thing, since it is endoscopy and IBD, I think we do need a statement, but that comes much earlier.
Yes.
Because where we are going to subclassify our IBD, is it Crohn's, is it ulcerative colitis, indeterminate, whatever it is. So the first 3 are going to come much earlier. The last 2 are going to come here, but with a little bit more of characterization, isn't it? Is it okay? Okay, thank you very much. Yeah.
So I would suggest that this should be, when the diagnosis is not clear, it should be endoscopic. A repeat endoscopy should be done. Everybody, there's a lot of data to show that even when you start giving antimycobacterial therapy in Crohn's disease, the symptoms respond, even the CRP levels come down. That's very clearly documented, not just from India, but even from outside. So merely saying clinical monitoring, just chasing the symptoms, is not appropriate. In fact, that will delay the diagnosis. I think the only question which needs to be addressed is whether you want to do a colonoscopy at 2 months or 6 months. That is the only matter of contention, but colonoscopy needs to be done if the diagnosis is not clear on initially.
Vishal, your point is well taken. I think I would suggest that multi-parametric approach, clinical monitoring and follow-up endoscopic evaluation. Why clinical monitoring is not important? No, it has to be a combination of all the three.
Sir, so multi-parameter unfortunately means
This
different
will come in
things.
discussion, no? If you just bring that whole thing in discussion, you'll be discussing Crohn's, business, tuberculosis, all those points will come in clinical differentiation.
This is not discussion. This is not a matter of discussion. This is, I think, is a matter of where there is evidence.
No, not discussion
Evid-
here. I mean, in that context, in that statement context, you can bring this in the discussion.
So, ma'am, there are two different situations. That one is, of course, you are able to make a diagnosis using whatever modality. Let's say a gene expert is positive. You have a diagnosis in day one. But when the diagnosis is not positive and you've taken a ATT trial, which is, I think everybody uses that, then how do you follow them up? I think that's a very important point
They've got
for
that
our
based
region.
on endoscopic and histology.
And-
They've got that.
Followed by a colonoscopic, yeah.
And yeah, I think so. The sentence needs to be rephrased or reframed to include ATT trial. Would I say? Does everyone agree that ATT trial needs to be incorporated into this statement? I see Ajit Sood shaking his head like this.
I think reality, I think this is a huge issue and people would look for guidance in this. Vishal, the question that I wanted to ask you right at that time was, at 2 months, do you expect all the things to disappear? Because we have seen partial resolution even in Crohn's disease. So that whether that 6-month criteria is actually better for complete resolution of mucosal disease.
If we are looking at ulcers which are not associated with strictures, we have seen virtually complete response. Only when they are associated strictures also, we see that the response is not complete with ATT. We are dealing with underlying TB. So this is an observation not published, but largely, a large majority, we will see healing of the ulcer. And I think it does because again, there is evidence from, again, AIG and also from Dr. Vineet's group. Yes. I think we can take a call because we are not realizing that we are also sitting at a place where MDR is rising. And that's the time when you actually reevaluate also. And that's a time to take biopsies and also get ultra is now available and maybe a culture can also be done. So that's a time to reevaluate your diagnosis also if the response is not happening.
So my question to the floor is basically, of course, I don't think we have time to go into the specifics about what we would do. Or should we be including this in the statements? If so, what is it? How is it that we need to, phrase it out? I think whatever we say, it has to include clinical monitoring. It has to include a follow-up endoscopy. Whether it should include a therapeutic trial of ATT, that is something that we need to discuss.
When a therapeutic trial of ATT is being administered, it is important to follow up these patients with a repeat.
No, that's all.
Yeah.
So about clinical monitoring, there's no argument. About follow-up endoscopy, there is no argument. What I'm asking the floor is that should we include the terminology therapeutic trial in this?
Reverse is also true. A patient of tuberculosis has been Crohn's. You can't say therapeutic trial, you just says you have to monitor because the reverse is also true. It's not necessary that you are giving ATT.
I'll just share one paper which recently has been accepted in the process of publication from AIMS Bhubaneswar. There what they did, that instead of giving a ATT trial, they started them on steroids, and there was worsening and dissemination, the higher microbiological positive. So in Indian setting, I think that's a strategy. One should, whenever there is confusion, ATT first the appropriate. But yes, on occasion, we are pretty sure that this is Crohn's disease, and then one may end up giving.
I think for making the statement, if we have to make it a concise statement, we have to say that endoscopic evaluation after 3 to 6 months based on patient's response. Because what Ajay said is very relevant, because some patient is worsening. You can't wait for 6 months.
But there is a clear-cut guideline that we have to repeat endoscopy first 2 to 3 months. When we are giving empirical anti-TB, we have to repeat it so that, because we know that if it is Crohn's, we know that he is going to.
This is Asia Pacific. There was guidance.
Guidelines are there.
At that time, there wasn't much evidence, but after that, there are 3 studies at least which have seen at 2 months and suggest that it is okay to give at 2 to 3 months. So 2 to 3 months is the.
And the second point is,
I think it would not be out of place, because as a corollary to that main statement, what follows is that, okay, this is not the ideal. What next? It has to be an approach which includes close clinical monitoring and a follow-up endoscopy, maybe at whether we mention 3 months or not.
We can probably add another statement saying that wherever there is a confusion, whether it is ITB or CD, and a therapeutic anti-tuberculosis trial has been started, it is recommended that at 8 weeks, repeat colonoscopy can be done and repeat biopsies can be done.
You mean to say one more?
Yeah, possibly.
Okay. Same thing. It's
Yeah,
a conveys the
you
same
not
thing.
added the term therapeutic trial. Therapeutic trial looking for a response. Endoscopic and histopathologic response.
Yeah. Comma, close clinical monitoring, comma, and a follow-up endoscopy is advisable. That is all. That's all. It makes it very, so that thing comes up as a corollary to that, so you just said that. Okay, then yeah, Devendra, yeah. It's on, but you're not audible. Yeah.
so we have to specify there that biopsies for AAB culture, gene expert, and adequate number of biopsies have to be taken for histopathology. But those form important areas. Because if we do it at index biopsy, if the culture is positive, then we have the DST for resistance. At that point only we can diagnose it.
So differentiating ITB and CD is difficult based on endoscopic appearance and histopathology alone.
In addition,
In addition to these, the following or
adequate
multi-
number of biopsies should be taken, TB culture.
gene.
That will come in the discussion actually.
So I think we can make it much more simpler by saying differentiating ITB and CD is difficult based on endoscopic appearance. I mean, despite that, if you have a problem, then comes a corollary that we need to go in for a. That's okay. Yeah, alone does not convey anything actually. I agree with you. Actually, should be endoscopic appearance, comma, histopathology and microbiological tests. Full stop. You stop it at that. And then the next one is that in case of uh, doubt, uh, a multi, we use that multi-parametric approach. Okay, fine, including including clinical monitoring, comma, and follow-up endoscopy and therapeutic trial is suggested. Yeah, so that's okay. Okay then. So thank you very much, Rajendra. Dr. Ajay, Dr. Jayanti, Dr. Rupa, and Dr. Vandana. Anil Arora is joined. He has contributed, but he was not able to come. Taking his place is Dr. Rupa. Now the thing is, we are in a dilemma, and I said the post-lunch surprise that awaits you is that since all these issues have been discussed in great detail in the pre-lunch session, we had an offer that we will relinquish this whole session in the interest of time so that you can finish early, you can have a look around. So do I spare the panelists of that effort of walking from their seats to their...
2,000 delegates are listening. I think we should continue because many people outside is also listening.
Okay, could I get the panelists quickly? Now, so what I'll use this session, we are given 40 minutes, but I'm sure we can finish it off in 20. Just to get some issues discussed, and this panel discussion, we are supposed to focus on the issue of mucosal healing with respect to IBD. Now, I would probably start off with Jayanti. Whole morning we've been talking about ulcerative colitis. Jayanti, I'm not projecting your slides. I just wanted to... now, are we 100% clear about what is this clinical remission, endoscopic remission, histological remission, and deep remission with respect to ulcerative colitis? Is there anything like deep remission in ulcerative colitis?
Basically, the clinic with the outcome on endoscopy and histology, that will be...
So in ulcerative colitis, our aim or target to treat is basically a combination of clinical remission
and endoscopic,
and endoscopic remission. What do you think is the importance of histological? Actually, Usha Datta did mention about histological healing. Do you think that histological healing is important, or it's just if you're happy with, if you get a patient with a clinical remission and an endoscopic remission, you don't want to?
Yeah, ideally, the studies have, different studies have taken, some studies have taken titers as something that should be reversed, or neutrophilic inflammation that should come down. So these were at least 3 or 4 studies have looked into this. And I think that histological remission has really not been fulfilled in most of the studies.
Does the floor agree with this? Talking about Ajay.
See, if you have what Jayanti said, that the data to show that histological remission is important is not there. But except for one caveat, I think basal plasma cytosis probably has a relevance for the remission.
Has relevance. So if you have a patient with clinical remission and endoscopic remission, you take a biopsy, and it shows plasma cytosis, you're worried?
It's not a question of worry. It's a question of that there are indications that it is important. These are patients who are likely to have more recurrences. And
Do we have data? Okay.
There are some studies where it has shown that histological remission would lead to better long-term outcomes. And once it is there, and there is the other way also, that presently, if we look at endoscopic remission, and in those patients we look at histological activity, the histological activity is still there. So there's a discordance which is there. It is an optimal target to look for histological remission, but still it can be used to optimize our outcomes as of now. If we have to change the medication, looking at it, it could be used for surveillance as dysplasia, for dysplasia. There are some factors which, I mean, ideally it should be done, but it is a difficult target to achieve.
Naresh.
I think histological remission is a bridge too far. I don't think we can achieve it with conventional therapy, and hence we have to be happy with achieving mucosal healing.
So you're happy with...
Our present target should be just in.
Ajit.
30% of patients who have endoscopic healing do not have histological. So there are some patients who do get this reversal, but I think almost overlap is about 30%.
So, okay, but just sticking on to what you said, 30% of patients who get an endoscopic remission still do not have a histological remission. Now, when you have such a situation, what would you do?
I will really not push my way towards histological. I will maintain a endoscopic remission.
But you'll be continuing the same. Does it have an impact on treatment?
As Vandana mentioned, I mean, if you get that histological, then the chance of hospitalization...
So would you upgrade or
I would
escalate
not
the
upgrade
treatment?
at the cost of adverse effects of the agent, especially the biologicals.
Probably increase the dose.
Not increase the dose.
Ajit.
to sum up this, Ramesh, actually we do not have the data that if we have to achieve the histological remission by upgrading the treatment, then will we have a strike the balance between the safety and the effectiveness. So that's the reason it is
So
not
still
recommended.
a matter of
It is not
conjecture.
recommended as yet.
Okay, Ajit.
In continuing with the same, that it has been now documented that people who have endoscopic remission may not actually have histological remission, and at the same time it has been now shown clearly that patients who have histological changes, even very minimal changes, which may be better seen with the enhanced endoscopies. I mean, when we compare their disease scores with patients who do not have even subtle changes, the patients who have some changes, they don't do as well as the other group. So there is importance of histological remission. At this moment, we say that it's difficult to achieve histological remission because there are many, many issues still pending. We don't know how many biopsies are good enough to label a patient as histological remission. We don't know what exactly site to target. And for histological remission to look for, we need a very expert pathologist who should be tuned to be looking for, subtle changes. And there are different criteria has come up without any universal agreement that what should actually be defined as universal as a histological remission. So, but if we say whether it's a desirable target or not, it's definitely desirable.
So a lot of gray zones.
Sir, question, Dr. Ajit, is what are the criteria? 3 different criteria have been used. 1, the complete absence of neutrophils in the lamina propria. 2, the regaining of the crypt architecture, the distortion architecture branching that disappear. 3rd, BLP, the basal lymphoplasmacytosis disappearing. So if a patient has 1, doesn't have the other 2, is he in histological remission? If he has 2, is he? Or do you have to have all the 3 criteria? Because if you take all the 3 criteria in different segments, jo Gibo's index hai, it's practically impossible to try and achieve that target.
It is not impossible to achieve. I mean, the latest PHRI, they are looking at epithelial as well as lamina propria neutrophils. Just even few neutrophils or even 1 neutrophil will show this is not total histological remission. There is a difference, like with time, newer criteria are coming up. I mentioned that this is one issue. There is no agreement that what should actually define histological remission. That is why I said it's a desired target. At the moment, there's no unanimous agreement, but this is something if we achieve, patients are expected to do well. And this will definitely help us in de-escalating the therapy.
Dr. Ajit, let me ask you, if a patient is showing mucosal healing on endoscopy and yet he is not having histological remission, are you going to upgrade the treatment at the cost of additional adverse events of even, he's on 5-ASA, he's on Imuran, he's on, let us say, even Remicade or biologicals, let's not take names. Are you going to upgrade it even more? Because when you upgrade your treatment, the risk of side effect goes up. So you, in trying to achieve that disappearance of whether crypt distortion or neutrophils in the lamina, there's a price to be paid. Nothing is free.
But if you pay the price and if you get the desired thing, it's worth it.
So, okay. There is a difference in opinion, but...
No, it's not difference of opinion. Question is, where do we want, to what level do we raise the bar? If we want to raise the bar to histological remission, we expect better results. And Dr. Puri's question is very pertinent, that what to do in case if there are still few neutrophils. Are we going to escalate the therapy or not? At the moment, answer is no.
No.
We will not escalate. But we know that this patient has not reached to a point where we wished him to be. I mean, whether it will be worthwhile escalating the therapy at the moment, we don't have a data. But this is an issue which he has.
So, would I be right in saying that this is within the realms of research a process? Because it does not now, from what the conversation that you've had, my impression is that the next time I have a patient there's a clinical remission, endoscopic remission, my question is, if it does not impact the treatment, why should I take biopsies? Why should I take biopsies if there is no impact on treatment? Okay, when you say that you're going to define a subset and we're going to prospectively look.
So, Ramesh, I'll answer that. I'll take a biopsy even if he has a patient, even if he has mucosal healing, I'll still take a biopsy, because if it comes that histologically his disease is active, I'm going to call him sooner for a follow-up. If he's in complete histologic remission, then there is data to suggest that at least 1 year or 1 year down the line, the chances of him getting a RAPS are probably less than 20%. So you can say, okay, you got histological remission, you see me after 10 months. I don't need to, after 12 months.
Okay,
you can prognosticate the patient.
Okay, fine.
You can prognosticate the patient very well.
Let's move on. So we've covered the first issue about healing endoscopic remission. We also covered the second issue about histological remission. This question was for Vandana. I think you are happy with this statement that you made. The third one, of course, a good clinical remission not accompanied by an endoscopic remission is an indication to add on or change treatment. Even though the answer that I've got is agree, but I think the flow of discussion suggests that it is not an indication to add on or change treatment. Am I right?
This is basically, here it's only...
you should be agree.
So if you have a clinical remission, no endoscopic remission,
then you have to change.
You add on the treatment, change. If you have an endoscopic remission, no histological remission, leave it like that. But the point that Amrinder did mention is that it will help in planning the follow-up.
Yeah, prognostication.
So that's good. That's a point well made.
See,
Right.
Dr. GN, CALM study, this is what CALM study has shown. That if you go to the endoscopic remission, it definitely helps in better disease control. But that was with adalimumab. Now there's another study, Stardust study, which has come with UST. UST is not in favor of, tight control. So that's symptom-based treatment. So there are two contradictory studies. At the moment, we really can't say whether we all agree on this or not. CALM study is definitely in favor, but Stardust study is not in favor.
Okay, fine. Jayanti, over to you. This was the issue that I had asked you to deal with about Crohn's disease. We've been talking about ulcerative colitis. In Crohn's disease, endoscopic healing is a desirable long-term target. Ileocolonic colitis.
That would be
no question about that.
That will also be ideal. Yeah, that ulcers should disappear. That's basic.
Now, for Ajay, this was a matter of contention. For small bowel Crohn's, assessment of treat to target revolves around CTE, MRE, endoscopy. There was a detailed discussion in the pre-lunch session. What more do you have to add?
See, when we are looking at a follow-up of assessment, I think the CT should not be done because you cannot have a repeated radiation exposure. We should restrict ourselves when you're talking about cross-sectional imaging, talk about MR. And secondly, enteroscopy, we had a detailed discussion on capsule as well as the device-assisted enteroscopy. I don't want to go into too much details of that, but I would like to add the evolving role, though it cannot be a part of the recommendation at present, evolving role of ultrasound. And there is a huge evidence coming that you can use ultrasound as a follow-up in these patients. It can assess, and there is some modifications, MSOT or something. So that's one thing we should be knowing about it. It's still not an approved thing. So I will define it MRI, oblique enteroscopy, and take CT out of it.
You will take CT out. It will be
Because
MRI
of the radiation exposure, not
versus
because,
endoscopic evaluation. Okay. Any other comments? Yes, your mic. Yeah.
That endoscopy picks up, but definitely the wall thickness is a very good indicator, and two good studies have shown. So I think the future is going to be abdominal.
Okay.
Yeah,
so that's,
sorry. Can I just...
Yeah,
one-
Ajit.
Like, Crohn's being a transmural disease, just absence of mucosal ulcers will not make sure this is a complete healing. Similarly, I mean, to pick up small ulcers, abscess ulcers or superficial ulcers, the sensitivity of MR entero or CT entero is not as good. So, like what we have in ileocecal Crohn's, we say that it's the combination of MRE plus colonoscopy. I mean, here also it's something like that. It's not MRE or enteroscopy. It can be MRE plus enteroscopy for total healing, mucosal as well as transmural.
Mike. Mike. Could one of you
oblique does not
loan
mean
your...
or, it is and or. Because the huge discussion took place in the morning on all the modalities, and we have gone through all these issues. That's the reason I didn't want
Yeah, we did not elaborate on that because we had a lot more discussion there, but then, yeah, Naresh.
The problem is they are expensive investigations. Some endoscopy would be invasive, not easily available, and comes with its own share of problems. And that is why ultrasound is picking up to be a less invasive, less expensive modality, which gives you reasonable information that you can base your decisions on. Apart from wall thickening, stratification, even Doppler activity to tell you whether it's active or not are parameters that you can assess.
What Naresh is saying is absolutely right, but at the same time, the only thing is that it is cheaper, it's available, but what is not available is the trained
expertise, and it is a very subjective.
Yes, I mean, we need to train our radiologists to do it more frequently, involve them in this thing. They are not interested in doing it.
Yeah, it's not subjective. It is objective, so I will disagree on that. And yes, I agree that there are not many experts available. It's our job to create experts.
So I think we are looking at the future, but at the moment, what would you think that a patient who's got isolated small bowel disease for follow-up, and if you have to look at healing, define healing in that particular patient, it has to be a combination of MRE plus endoscopy or MRE alone or endoscopy alone.
No, you can say radiologic imaging and enteroscopy, which can be capsule or even.
So you're talking about both together.
And
and
both
you're
are
saying both
complementary,
together.
yeah, complementary.
That's what I'm asking.
Yeah, complementary. You can say radiologic imaging and enteroscopy.
Okay.
That's it. And you can say ultrasound seems promising.
Okay.
Follow-up is that it has to be practical.
Okay, fine.
If anything that is not practical or too expensive is something that we cannot suggest. You can do it for the odd patient, but not as a rule.
The next issue, of course, was transmural healing is a desirable endpoint, and this is something that we had discussed a little while ago as it correlates with disease course. However, we don't have any much evidence to suggest that it can be implemented. And so more data is required to recommend its implementation as an endpoint in clinical practice. Would you agree with that? Absolutely. Okay. The next issue was biomarkers remission is desirable intermediate target in Crohn's disease. It could influence treatment. What about this? This has been discussed. Okay. I'm talking about persistent perianal fistula despite endoscopic remission. Dr. Jayanti, a few words on this particular issue before I throw it open to the... you have a situation where the perianal fistula is still persisting, but you have endoscopic remission.
Yeah, I think we've not discussed perianal fistulas at all today.
But there is an endoscopic remission.
Here, endoscopic remission is there. So alternatives to the regular biologicals, that's infliximab, would be, there are new advances that are taking place. Basically, endoscopic procedures like placing in plugs or glue or injection of glue. And some people have even used clips to close the fistulas. And of course, newer procedures are the use of stem cell and anti-metalloprotein, MMP.
So you have to go in for some local...
So an advancement of this flap is being recommended by surgeons. It's something that's happening.
Fine. Yeah, Devendra.
So basically we have to mention here that perianal healing, for healing of perianal fistula, we need higher drug level of biologic. Even after that, there is no healing, then yes, all these approaches are right.
How often do you get a situation where in a patient with Crohn's disease, you've given biologics and there is good endoscopic remission, but the fistula persists and discharge continues? So what do you do in such situations?
Some of these patients we have placed long-term setons, so for a year or so, and they have done quite well. Especially those who are not affordable for biologicals.
Yeah.
So would a more aggressive surgical approach be useful?
Yes, definitely. Because there is no mucosal disease, then the local approaches will have to be.
The final issue is maybe a little bit provocative, but we don't have data on this. Clinical remission plus biomarker remission is as good as endoscopic or histological remission in Crohn's disease. Would you agree with that or not? Are you still hook on to an endoscopic and histological remission? A patient with Crohn's disease comes back to you, he's on treatment and his much better clinical remission is there, biomarker remission is there. Would you feel satisfied, or would you still insist that go ahead, upscale the treatment, escalate the treatment because you need endoscopic or histological remission?
I would think so. The reason is that both fecal calprotectin and CRP do not perform as well when we are talking about small bowel disease. And that's where the big problem is. And because they don't, we don't know and we know that clinical symptoms are very unreliable. And hence, I would use even, if you want to call a third-rate test like an ultrasound, to give me some confidence that it is working.
Is that opinion shared by everyone, the panelists? Any differences in opinion? Because this feedback, this input has come from Anil Arora, and he felt strongly that endoscopic histological remission is better compared to clinical remission, biomarker remission. And I think this is an opinion that is shared by everyone without reservation. Of course, Ajay, before I end, this is something that you had included in your presentation, and I was quite impressed by this.
Actually, say from the Simon Travis article of 2012 or 2014. So he summed it up very well that there are certain steps that we have taken. We have not taken the ultimate step. Like Mayo, basically, when you talk about ulcerative colitis, and Mayo is a clinical, and UCS comes to that. So he's still, I mean, we are at the same stage that the histological is a stepwise ultrastructural healing and the functional healing, they will follow. But what it guides us in implementing the treatment or changing the treatment, we are not clear about it. Will it change the natural course of disease? Will it change the complications? Will it change the surgery rate? Will it change the hospitalization rates? All those things are not clear. But we have reached the second step of a endoscopic this thing. Same way as in the Crohn's. I mean, it stands true. The only scoring system changed, but everything else is the same. So this is a good picture to look at. It's actually, I took it from Simon Trevis' article.
Reflective of our changing perspective and management of IBD. And finally, of course, I was asked also a part of this panel to actually look at the mucosal healing rates of various categories of medications that we use for inflammatory bowel disease. And you find that, on the left, on the right, as was pointed out, histological healing, we have very little information. And whatever little bit of information is there, the results are quite varied. And I don't think we can really, look into it a lot. But if you look at the mucosal healing rates, and if you look at one of the references, number 3, it's basically, I think, 3 years back, you find aminosalicylates 68 to 80%, which is high, and in patients with ulcerative colitis. Your comments, Ajay, aminosalicylates, azathioprine, infliximab, and then you go down to tofacitinib, and in between you have vedolizumab. I mean, these are the drugs, probably go-to drugs for ulcerative colitis even now. But I'm impressed with the figures of aminosalicylates.
GN?
Yeah.
GN, probably we're looking at apples and pears. See, aminosalicylates are the first line if you're looking at, the bottoms-up approach, or go from the bottom of the pyramid up. Whereas all the biologics are probably used for,
so they come into the scene much later.
Disease,
that is why you have...
If it is a top-down approach,
they are
then
the
whole
different
thing
kind of patients. The patient population differs. I mean, 5 years studies are basically in the mild disease. That's why there is a high response rate.
But would you agree with this figure of 68 to 80%? Because, in the morning we were told that mucosal healing rates with aminosalicylates and ulcerative colitis may not be as high as this.
We should take patients with very mild disease. I mean, 5 years alone are indicated only for mild disease.
Okay. Ulcerative colitis. We don't. No. Mucosal healing is, what is the definition of mucosal? The mucosal healing is defined, it's an endoscopic appearance. It is an endoscopically defined.
Achievement, I think, of 0 and 1. Mayo 0 and 1
0
is
and 1.
considered as endoscopic.
That is endoscopic healing.
That's true. It's called endoscopic remission.
Okay.
Dr. Ramesh, even for
Ramesh, just to reiterate what the conversation we had earlier, look at your healing, mucosal healing in Crohn's is something that we can't achieve. So what endoscopy are we trying to look for to achieve healing? Something that we can't achieve, let's accept it.
Yeah. Okay.
More point.
So,
see, what has been the definition of MH or mucosal healing? Some people have taken 0, some people, Mayo some
Mayo
people
0,
have taken
1.
0, and some people have taken 1. And there are at least 3 good studies which have shown that the relapse rate of Mayo 1 is much more than Mayo 0. So this group is putting pressure that we should go for Mayo 0 as MH and not as Mayo 1. So that is also there.
So,
That is there.
Okay.
That is there.
So one of the reasons why this particular panel discussion was kept in the post-lunch session presumably was to give time for the audience or the floor to have a siesta. But I'm so happy that the panelists and myself, we prevented such an outcome, and all of you sat through it,
Yeah, but
took part in it.
but actually,
It was
Dean, I think you should. We had all the slides, but we're all
thanks
present.
very much to the panelists. I'm sorry I did not project your slides.
No problem, no
I just modified the last one because I did not want it to be a repetition.
Yeah.
I did not want people to just go to sleep. And thank you very much. And it's back to you, Rupa.
answers have more or less been covered.
Yes.
So,
we
quick
have
Partha,
already
you can.
reached consensus. So Partha will discuss the of fistulas and abscesses. Yes, you could show the statements straight away.
Yeah, sir, I have few things to show, sir.
Okay,
Yeah.
but be
Yeah, I'll finish in 10 minutes, sir. So, without wasting any further time, I'll straight away go to my talk. So, usually these mechanical complications like stricture fistula usually develop after 4 to 5 years of disease, and as there is no effective antifibrotic therapy, at that point of time, endoscopic therapy or surgery is the only management that is possible, and these complications like stricture, fistula and abscess occur in a specific sequence, and most of them may be coexisting. It is very important to understand that to treat them. So while you are treating a stricture or a fistula, there is only few actions that are there that can be done. In a stricture, you can either dilate, cut or put a stent. If there is a fistula or abscess, if there is an associated stricture, you dilate first. If there is an abscess, you drain first. You may do it endoscopically. Along with that, you can cut or fill the fistula with a glue or close it with a clip. So these are the basic actions: dilatation, cutting, draining, filling or closing, or a stent placement. So these are the equipments for dilatation, we all know. Cutting, these are the different settings told by different experts. Usually it is EndoCut Q313, and the cutting wire length is very important to decide on the depth of the incision that you are making. That acts as a visual guide. For drainage, you can do a knife, you can put a pigtail through endosono. If the IR cannot do it because of the overlying bowel, you can put a vascular set on endoscopically. You can do suturing, you can put SEMS, you can put a OTSC. So usually for strictures, we are discussing only Crohn's disease and IBD associated surgery-related strictures. We are not discussing ulcerative colitis because for them, we should have a very low threshold for resection. And these are the circumstances: more than 4 strictures, then more than 5 centimeter strictures, more than 5 centimeter proximal dilatation, purely inflammatory strictures, fistula or abscess within 5 centimeter. These are absolute contraindications. You should be very careful. De novo strictures, pinhole strictures, anal canal strictures. In this also you have to have a little bit of caution, like incontinence can occur if there is a complication in the anus. So then anastomotic stricture, ileocolonic, rectal stricture, pyloric stricture and fibrotic stricture are ideal for endoscopic therapy. So case selection is important, as we know that the anterior wall of the rectum is the forbidden zone, already discussed by Dr. Gursimran. I am not going to this again. So these are the different zones that landmines have to be kept in mind, and also the post-operative anatomy has to be kept in mind, because as in this case of high ileocolonic anastomosis, the consequences of iatrogenic perforation would be similar to a duodenal perforation. So it has to be kept in mind. So this is the approach to the stricture. It is almost similar to what he said, but I would like to add this Bacardi risk score or other nomograms that are available for these strictures. At the onset, you can decide that this patient is not going to respond to endoscopic therapy, and you can directly go for a surgical therapy in these patients. Like almost all the studies have shown that pre-stenotic dilatation is one of the factors. And for less than 3 centimeter strictures in Indian context, we can do either a balloon dilatation or a stricturotomy rather than only doing a stricturotomy. If the initial method fails, then you can do a stricturotomy if not done earlier, or put a SEMS, fully covered SEMS for longer stenosis, partially covered for shorter ones, and LAMPS for a shorter and distal stenosis. The recent North American review, they have removed this 3-5. They have reduced less than 4, more than 4. So that is the only difference. Steroids should be tapered to less than 20 mg per kg, 20 mg, and biologics can be stopped. This is the largest systematic review of endoscopic balloon dilatation, and the Achilles heel of balloon dilatation is the recurrence, which occurs in almost 50% cases, and 2/3 will require redilatation or surgery. This is our experience of around 44 patients, 56 strictures, and 87 sessions of dilatations, and we have dilated almost everywhere. And I will show 2 examples where there are ulcerated strictures and in the IC valve and also in the sigmoid, in which we have dilated very carefully carefully, and the patients avoided resection, and they are actually doing good on endoscopy, this medical management right now. Another case of pouch stricture in which after recurrent dilatation, there was still this, it was recurring and it was found out to be Crohn's disease of the pouch. So our results were similar to the meta-analysis, except for the fact the recurrent symptoms were little less because of the short follow-up in our study. And that's why, because of the recurrence rate, you need stricturotomy, that radial incision, and then you can cut the fibrotic tissue and put the stricturoplasty with clips, which acts as spacers and also prevents rebleeding. So what is the advantage? Advantage is this a long-term success rate is higher with stricturotomy, whereas you can, the disadvantages are it needs training. It can be only be done in the proximal or distal bowel where the shaft is straight and the tip is under your control, whether you can cut it. And the drawbacks are bleeding rates requiring transfusion up to 10%, and also you can actually target a non-ulcerated area in the stricture. So these are the studies he has already referred. I am not going into details. So it was shown to be similar, the recurrence rates were lower than balloon, and reintervention rates were similar to surgery for ileocolonic anastomotic strictures. So like in the treatment of achalasia cardia, the treatment may shift from surgeon's knife to endoscopist balloon to endoscopist knife for IBD strictures. Then going to the stents for IBD stricture, these are the stents that has been studied in IBD strictures, and you should determine the length of the stricture based on the stricture length, stent based on the stricture length, because almost all of the stents undergo 5 to 40% of shortening, and the main Achilles heel of stents is migration. So that's why partially covered stents were developed to reduce the migration rates. Lumen apposing stents have been used for distal and very short strictures, but because of short delivery catheter, it is not for proximal stents because it is designed for one, and biodegradable stents, still there is not sufficient data. So you should radiographically examine the length of the stricture and sometimes fix the stricture, because the migration is the main side effect with OTSC or suturing, and fully covered SEM should not be kept more than 4 weeks, and partially covered SEM should not be kept more than a week. So this is the meta-analysis which is showing migration can occur in 44% cases, and almost 17% have pain requiring stent removal. So these are the adverse events. And this is the only randomized control trial which has compared this with endoscopic balloon dilatation, and it was seen that requirement of additional intervention at 1 year was almost 49% compared to 20% with balloon dilatation. So the same recurrence problem remains with this. So we are still yet to get the ideal treatment. So regarding the fistulas, you should not treat which fistulas with endoscopic therapy: malignant ones, complex ones, long ones, deep more than 2 centimeters, gut to hollow organ. You should be very careful, like a rectovaginal fistula or a pouchovaginal fistula. But it can be done in some situations. Gut to skin, like intracutaneous fistula, OTSC use has been described. So what are the steps? Initially you drain or dilate the abscess or stricture, then locate the feeding and exiting site, open the fistula tract by doing a fistulotomy. The underlying concept is acute leak, you do a closure. In chronic leak, usually it is a transmural disease and fibrosis. If it is a short, simple and superficial fistula, you can just cut open the roof and you can open it, as you can see in the ileocolonic pouch to pouch or perianal stricture. Then the step 3 is either to close the feeding side or fill up with the injectable material. And most of the cases, like in perianal, pouchovaginal, if there is an associated stricture, you treat the stricture, it may heal spontaneously. In intracutaneous fistula, you cut the skin side more for adequate drainage. If you close the exiting side inadvertently, it may lead to iatrogenic abscess formation. So this is an example how we have done an endoscopic set-on placement. We put the catheter inside and we put the jag wire from this is a simple fistula. This patient was having recurrent past discharge on biologics, and we railroaded that jag wire and put the set-on through it and then tied that, and that avoided a surgery, and we could give the biologics on time for this patient. So it can be done. I have presented a pneumonic SBP, short, superficial, simple, bowel to bowel and pouch to pouch. You can do a fistulotomy. Avoid in DSLR, like deep sphincters, avoid the sphincters, long, more than 3 centimeters, rectum anterior wall. And also clipping, stenting, this should not be done in rectovaginal or pouchovaginal fistulas, and it can be done in case of intestinal side in intracutaneous fistula. So I'm not going into detail. And another novel technique has been described, which is called fistula ESD and clip. You cut the submucosal tissue and put OTSC to approximate the muscle layers. That has also been recently described last year in endoscopy. So troubleshooting is important. I'm not going into details, but in IBD, actually managing the complications may be more difficult because of the altered anatomy, underlying gut disease, submucosal fibrosis, poor bowel preparation, concurrent steroids or biologics, and poor nutritional status. So not only it can act as a failure breach to the surgery, also it can help to manage the post-surgical complications. Like in our series, we have reported 5-6 cases of pouch, and the principles remains the same. So this is the take-home message. Stricture therapy, basically there are 3: dilatation, cutting, or stenting. Dilatation is the first line. Cutting can be done for short strictures and stenting for refractory long ones. And dilatation anyone can do. Cutting has long-term success, whereas stenting specifically you can use for a long stricture. Dilatation, recurrence is the problem. Perforation is also another problem, is higher than cutting. Cutting, the problem is bleeding, limited indication because you need a little elevated stricture and learning curve. Stenting, the problems are migration, pain, cost, and reintervention. Fistula and abscess, 4 functions are there, that is drainage, cutting, filling, or closure. The drainage for abscess and cutting for superficial simple fistulas, bowel to bowel or pouch to pouch, both of them can avoid surgery. And if you don't do it incompletely, then you may produce complications. Filling, like filling of the fistula, is very easy, but the durability is questionable. Closure, only it's an easy procedure, but because we have to know that it is a transmural disease, so not to be used in de novo, rectovaginal or pouchovaginal fistula, and there is risk of infection. So thank you.
Thank you, Partha, for this beautiful illustrated lecture. I think we'll go on to the second part of this therapeutic endoscopy. Rajesh is going to discuss what happens when you detect a malignancy or dysplasia. We can have questions and answers later and look at the statements. Rajesh?
Good evening, everyone. Would like to thank Dr. Reddy sir, Dr. Rupa, and team AIG. I'm going to talk colorectal neoplasia, EMR, ESD, and FDRD. I think this slide has already been discussed by previous speaker. IBD is associated with the increased risk of colorectal cancer, and the cancer risk increases with the duration of the disease. The CINIC guidelines avoid using the term like DAM or mass-like lesion in the colitis that is visible or invisible. And what is visible is, one, identify on target biopsy from the lesion that is seen during the colonoscopy. It may be polypoidal or non-polypoidal. And the invisible, which is identify on random or non-targeted biopsy without a visible lesion in spite of using advanced endoscopic imaging. So the terminology is now visible lesion, non-visible lesion, and visible is polypoidal and the non-polypoidal. The visible dysplasia, then again endoscopically resectable or endoscopically non-resectable. So if the endoscopically resectable is, which is clearly visible, distinct margin, appear to be completely excised on visual inspection after endoscopic resection. Histological examination of the mucosa adjacent to the resection site is dysplasia free, that is called as endoscopically resectable. And endoscopically unresectable, which is ill-defined margins, submucosal invasion, asymmetrical lift, ulcerated or the large depression, flat neoplastic changes with the distorted pit pattern adjacent to the lesion. So that is called as visible dysplasia but endoscopically unresectable. Now, endoscopically you can remove by the endoscopic mucosal resection or by endoscopic submucosal dissection or FDRD. And EMR is relatively an easier technique. But the complete removal is not achieved in all the cases. Low complication rate. Completeness of excision is difficult to ascertain, and recurrence is greater in comparison to ESD. While ESD facilitated the end block resection, lower rate of recurrence, technically challenging, higher complication rate, greater expertise are required. In FDRD, there are a few cases report in the available literature. So endoscopic resection with a close surveillance is recommended over a colectomy for endoscopically visible and resectable lesion. The CINIC guidelines recommend if the visible dysplasia is deemed endoscopically resectable, en bloc EMR is performed, or other option like ESD, or there may be a hybrid procedure. There are one case report in the literature that is a single adenoma which is fibrotic, non-lifting in the descending colon where the FDRD was done. The CINIC guidelines also recommend that biopsy of the flat mucosa surrounding the resection site should be negative or free of the dysplasia, and tattooing or the photo documentation of that site for the future facilitate the future surveillance in these patients. So by EMR technique, only 47 to 63, roughly 2/3 of the patient can be removed, which is larger than 2 centimeter. Mainly two modalities, EMR and ESD. EMR is advisable in the polypoidal lesion, non-polypoidal lesion with a clear margin, without fibrosis and which is less than 2 centimeter, while ESD is a non-polypoidal lesion with fibrosis or more than 2 centimeter. This is the these are the two, one is in the European study and there's another study. These are the demarcation between the EMR and ESD. So this is a paper which was published in Journal of Gastroenterology Hepatology, where they find out which lesions are better for EMR and which are better for ESD. So total lesion was 102 in 74 patient of ulcerative colitis, and mean size of the lesion was 12 and non-polypoidal was 55. So what they have shown that the lesion which is 11 to 20 millimeter, the R0 resection rate was significantly higher for ESD, that is 94% in comparison to EMR, which was 55. So one of the point is, if the lesion is less than 11 millimeter, EMR can be done. If the lesion is more than 11 millimeter or more than 2 centimeter, ESD is a better option. Similarly, the R0 resection in the non-polypoidal lesion, R0 resection rate was significantly higher for endoscopic submucosal dissection than for endoscopic mucosal resection. So if the non-polypoidal lesion is there, then it is better to do the ESD. So endoscopic resection, total lesion was 102, perforation happens in 4, no local recurrence was occurred, and metachronous lesion, high-grade dysplasia was seen in 3 patients. So ESD is suitable for more than 11 millimeter non-polypoidal tumor, where EMR is acceptable for less than 10 or 11 millimeter of the lesion. This is this paper suggests. So these are the various studies. Total number of the study was 10, which studies about the safety and efficacy of the endoscopic resection. Out of them, 5 was mainly for ESD and 5 was for both ESD and EMR, but these are retrospective or prospective cohort studies, and where the number of resected lesion, the success rate was up to the tune of 90%. And surveillance after index resection is, according to CINIC guidelines, surveillance colonoscopy within 3 to 6 months, then repeat colonoscopy at 12 months, and then annual thereafter, biopsy of the resection site to document the removal of the all dysplastic tissue. But according to the American Gastroenterology, you don't require to take the biopsy from the surrounding area. So outcome after endoscopic resection, this is the meta-analysis by Bapu P. Mohan, 18 studies, 1,037 patients, 1,428 lesion. Ulcerative colitis was in 933 and Crohn's disease was in 126. And follow-up duration was 6 months to 82 months. And what the outcome of this meta-analysis was, pooled risk of colorectal cancer was 2 per 1,000 person per year. The pooled risk of high-grade dysplasia was 2, again 2% per 1,000 person per year. Pooled risk of any lesion was 43 per 1,000 year. Pooled rate of patient requiring surgery was 9.9. The pooled rate of bleeding was 2.2% and pooled risk of perforation was 2%. And these are the patients, like I said, about 9.9% of the patient require surgery, and these are the reason these patients require surgical intervention. And outcome after endoscopic resection, because of the less number of the cases, what they have done, rather than subgroup analysis, they did the meta-regression analysis, and what they found that the location, size, type according to the Paris classification, resection technique, EMR or ESD, en bloc versus piecemeal, any lesion histology did not reveal any influence on the reported outcome in the form of complications. So this is the recently published in 2022 article which was published by Q Sen Zhang. It was in 8 studies, 192 patients, 203 lesions, and all these patients are UC. Earlier patient has a Crohn's disease also. In this, out of 9 studies, first 3 were from the previous P. Mohan group. But in this group, all the patients are of the ulcerative colitis. Again, 5 are retrospective and 5 are prospective studies. 5 are single center and 5 are multi-center studies, both retrospective and prospective cohort of the studies. I think this, what they have written, is wrong. Median duration is 13 to 29 year. I think this is the month they should have written. But what they have shown that the lesion, what is the outcome of this is, the en bloc resection was achieved in 94% of cases, R0 resection was in 84, bleeding was 8%, perforation was 6, local recurrence was 6, metachronous tumor was in 6%, and additional surgery requirement after ESD was in 10% of the cases. So my recommendation is endoscopic resection is better to be done in patient when the underlying disease activity is in remission and with the mild activity. And I feel it should be a strong recommendation with the level of evidence is grade 4 and grade 5. The second, endoscopic resection by EMR or ESD with a close surveillance should be preferred for endoscopically visible and resectable lesion, irrespective of site, size, type, and lesion histology, either it is a high grade or low grade. Again, I feel it should be a strong recommendation with level of evidence is 4 and 5. Third is ESD can be preferred over EMR for more than 11 millimeter lesion and non-polypoidal lesion if expertise is available, giving high R0 resection. ESD can be technically difficult due to submucosal fibrosis and hence may require assistance of various traction in the water jet technique. Again, it is a conditional recommendation with the level of evidence is 4 and 5. The last is FDRD can be considered for left-sided lesion. This is my feeling because patient has a disease of the lesion less than 2 centimeter with a significant submucosal fibrosis, or you see the invasion. Again, a conditional recommendation with the level of evidence is 6. Surveillance colonoscopy to be done at 3 to 6 months, at 12 months, then annually, strong recommendation with the level 4 and 5. Thank you. And these are on the basis I made the level of evidence according to this chart. Thank you. I think I finished in 10 minutes.
Rajesh, you did not. What about multifocal lesions or where there are a lot
Yeah,
of
so
these
actually
pseudopolyps?
I have not shown one slide. Like I listened the word from Dr. A.S. Puri, searching the snake in the grass when you have a multiple polypoidal lesion and how to pick up. So this is the area which needs to be mentioned separately. What should be approached in these patients? Like you have a carpeting of pseudopolyps and you find a lesion, then there are some missing lesions maybe. So I think this is the area which we needs to discuss in the discussion. Actually, I was supposed to put this slide, snake in the garden, how to search in the grass. I heard from him yesterday only.
Actually, if you have a problem like this,
If the snake catcher is good, no, even if it is in the grass, you can take catch the snake. Anyway, I just want to know invisible lesions.
Yeah, invisible lesion.
How will approach?
So yeah, so if you look at the recommendation, if there is an invisible lesion and it found a dysplasia on endoscopy, it is recommended that you should send to an IBD surveillance guy and who do with the surveillance endoscopy. And if he can pick up, it is okay. Otherwise, patient should go for a colectomy.
Right, the first part is right. They should send it to a center where they are doing that. And if it's low-grade dysplasia, you need to do a follow-up thing. And if it's confirmed...
So again, the level of evidence available is only 5 because the few case report. But yes, initially people goes for the colectomy, but what you are saying is also right. The recent paper published by Mohan and Dr. Rupa. So if the invisible lesion is there in the low-grade dysplasia, you can follow these patients, close follow-up.
What I'm telling is, should we add a statement for that? Non-visible lesions. Suppose you get biopsy showing high-grade
could
dysplasia.
go back to the statement
Yeah, because
that, finalize the wording, or we need,
so for
fine tune the wording.
No, we have not.
So this is a strong recommendation. We feel evidence is not there, but we feel that yes, it is there strong. So this is the level of
Rakesh,
evidence.
We have not put a statement regarding random biopsies. We have said that if you are doing high definition, plus minus some kind of chromoendoscopy, that's good. So random biopsies we have not addressed at all. We have only put targeted biopsies.
Show my slide.
You are doing either of the or
No, it is also the proviso that is an expert trained endoscopy.
yes.
That is an important thing that needs to be emphasized.
according refer to a but
Exactly.
the question is when there are no experts or you are an expert in the making yourself, then what do you do?
So if it is in an expert hand, perhaps he may not do random. If you have not an expert, you have to do random.
So can I interrupt in between? So that's why they said on the random biopsy, because endoscopy is done across everywhere where the facilities are of expert IBD endoscopist is there or where it is not there. So on random biopsy, if you find, refer the patient to a center where the expert IBD endoscopist is doing, and then he do the chromoendoscopy and try to see. And if it is not there, then yes, you can follow up. If it is visible, then you remove endoscopically. So this was the concept of.
Some of these statements and can you, Rajesh?
Yeah, I'm just. So first I made this. Is the endoscopic resection is better to be done in a patient when underlying disease in remission or with the mild activity.
One question about that.
Quiescent disease, we can change the word.
Yes. This can be modified later. We agree in principle to the message of each statement. Yes. Next, Rajesh. EMR or ESD?
Endoscopic resection by EMR or ESD with the close surveillance should be preferred for endoscopically visible and resectable lesion, irrespective of site, size, type, and lesion histology. I have not written number. Site and size I have written. I have not written number. We can write in the discussion.
Should go for colectomy after this. That needs that.
Yeah, indication of colectomy should be a statement. Yes. So that indication of colectomy not only involve this but the other area also. Patient is a. Okay.
One factor, Rajesh, not been covered is detect a lesion, mass lesion, polypoidal lesion, which is malignant. Which is
Go for a surgery?
Yes, so that again brings in indications for colectomy.
Malignancy does not mean that you should always go for surgery. Malignancy depends upon, suppose it's an intramucosal carcinoma.
No, intramucosal is part of high-grade dysplasia.
No, what I'm telling is
beyond dysplasia. Yes.
No. In colon, even if it is a little bit, it goes up to the submucosa, it go up to 1,000 micromolar.
In IBD, talking of specifically in
I don't know whether in IBD it is different from the other one.
Sir, I think if you see the word No, but if you see the word endoscopically visible and resectable lesion, you know very well which is resectable and that says that this is. Which is unresectable, definitely go for a surgery. The message is very clear with this, which is endoscopically resectable. Hmm. Yeah, that's true. That's true. Yeah. But here we are talking to whom you are going to do EMR and ESD. You have done EMR and ESD and your margins are positive, then you subject the patient. So we are only talking EMR or ESD in a lesion which is endoscopically resectable. So it's written, sir, endoscopic resection by EMR or ESD with a close surveillance should be preferred for endoscopically visible. Number one, that point is clear, it should be visible. Second is, it should be resectable. And if it is resectable, you do
If
it.
it is not R0, then what happens?
Then patient go for a surgery.
So that needs brought in discussion. That is the point. So these statements will, each of these statements will have following discussion.
Okay.
So that's the issue. Yes.
Yeah, for R0 resection. Yes, that's
That, see, here,
Sir, in any curative resection of ESD, it is mandatory that you have to pathologically curative resection means, all margins are free.
Yeah.
And also, not only it's free, if you have to call it as an R0, in esophagus it is with this much depth, stomach is this much, and colon is up to 1000 micromillimeters. So it is all very clearly described. But I don't know whether in IBD
this has
it is
not been
different.
described for the IBD, this
No,
has been
I don't
described
know
for the
whether
normal.
There
IBD
is
is different.
loss of layer pattern in IBD, so it is not possible.
in IBD, what is
It is loss of layer pattern of the gut, so it may not be possible to
no,
actually.
but in IBD, what is clearly mentioned that
Yeah.
you must take biopsies from the adjoining
That is true,
tissue
that is
to
true.
make it clear. Give no ambiguity. Now, this question, statement, Rajesh, most of the literature will say more than 20 millimeters. You have picked one article to say 11 millimeters. The rest of the papers all say this JGH paper you are quoting to make it 11 millimeters. The rest of the articles mention 20 millimeters as the cutoff for EMR versus ESD.
Yeah, this is a meta-analysis which has shown about 11 millimeters.
No, this is the JGH paper.
Yeah.
But the meta-analysis has given 20 millimeters.
So actually I made it 2 centimeter by during this talk, I made it 11 millimeter. We can go up to the 12.
No, the reason
the
is,
threshold.
is that some of those papers have come from Chinese and Japanese who are more aggressive. The Europeans are quite happy doing piecemeal, even up to 20 millimeters. Pradeep Bhandari's paper is there, which shows that, and they are quite happy. So I think it really goes about what their skills are and what their
So let me just tell you, the lesion which is more than 20 millimeter where you do an ESD. But in the EMR group also, when it is 11 to 20 millimeter, you may not get the en bloc resection or you may not get the R0. As it was rightly said in the previous also, your chances of getting R0 resection will be higher when the lesion is 11 millimeter. When you choose cutoff as a 2 centimeter, your R0 resection rate is less. So that's why the 11 millimeter you will get a better R0 resection. And chances of successful is more.
Rajesh, just one point that for 21, beyond the JGH, clearly said, I have a copy, that says 20 millimeters is the cutoff as of that to make it EMR versus ESD. So we'll cross-check that and use whatever the documentation is there.
Even it will
I
be too
think
aggressive, I
what
think.
I suggest for this is that regarding the technicality in the points, I think Partha, Dr. Kochar and Rajesh, you can just discuss and then fine tune it and then send us the statements. Because we really don't have the direct knowledge right now to frame the sentences. So on one side, Dr. Vishal and Dr. Partha, Rajesh and So just like for Dr. Usha's statement, so these are the two areas where there has been gross.
I think it should be 20 only. That
It
11
should
is
not go
for my
as-
single study only. Sir.
Partha, let us just discuss that in a separate, fresh session. And I think, Dr. Kochar, we just go on for the final.
Yes. I think we will thank everyone, particularly Dr. Gursimran, who joined us from afar.
And IBD ENC. We know that for making any recommendation, either you have to have a guideline or a consensus. Mostly we prefer consensus because it is easy and it is rapid. Guidelines is time consuming and the process is very exhaustive. When you come to the IBD endoscopy, we know that endoscopy in IBD has all the areas to be covered, and we have covered many areas, which I am not going to details. All these are discussed in detail. But what we did not discuss or we did not stress upon, one is the description of endoscopic lesions, especially in Crohn's disease. And what is the risk and complications of endoscopy in IBD? Is it different from a conventional group of people? And what is the quality of endoscopy? Should have adequate training for endoscopy in IBD, or there should be a specialist course or exposure for this. All this need to be added on that. Then one more thing which we discussed, but we did not position it properly, that was positioning of upper GI endoscopy in IBD. Where should we position it? And what is the timing of endoscopy for mucosal healing? We had a lot of discussion on that. So did we really decide based on therapy, 5-ASA, immunomodulators, biologics, and all these things, and when should we look for healing of the mucosa? And when we say about mucosal healing, what about small bowel Crohn's? How can you assess the healing of that? And also, in our situation, we know that we need to treat the target, and in those situations, our final thought process is that to have a transmural healing, and what is endoscopy is sufficient enough to tell about that. Another thing which we discussed but not discussed very well was IBD differential between tuberculosis and Crohn's disease. When, suppose you want to give a trial of ATT, when to repeat the colonoscopy, 2 months, 3 months, 4 months, and even after clinical response, will we repeat at the end of ATT or not? Another is, we have not mentioned anything about endoscopic ultrasound in IBD. It's also quite important. We know that EUS has got at least some role in inflammatory bowel disease. And also, biliary complications do occur in patients with IBD. So should we include biliary interventions, especially primary sclerosing cholangitis, etc., on the endoscopy session of IBD or not? And also on management of IBD after surgery. Should we include in this one, or we just tell and pass off? Because you know what I think, at least for some group of people, what they think is surgery is the end of the road. After there's nothing. And then later they come to us with complications. Then future directions, image enhancing endoscopy. Especially I have seen on slide passing off that there is no role for, or at present there is no role for, all the high-end confocal laser endomicroscopy, etc. But there are certain upcoming knowledge in endocytoscopy. But this is a terminology for endoscopy lesions, which I am not going to detail. And risk of endoscopy in IBD, we have mentioned partially, but I think we should go in detail and little bit should be added on that. And quality of endoscopy should be mentioned on that. It's a very important thing. And third is upper GI endoscopy. We have not positioned properly. Does it recur or not? And one more thing is that I have raised this question. But you take antral biopsy. I do routinely, and I have seen many times I see granulomas extensive in the antrum. So will you label them as, will that change the extent of disease? And mucosal healing. I still have a lot of doubts how to follow up a patient of small bowel Crohn's. And even if it is a Crohn's involving large bowel and small bowel, even if the large bowel is healed, how will you know whether the small bowel lesion mentioned in a group of, because in India it is quite important, you are giving a trial of ATT. When will you call the patient for repeat assessment? And what will you do? Will you take biopsy again? All these things should be, at least you should. For IBD specialist, they lack the technical skills in advanced endoscopy. So there is a growing interest and there is a need for endoscopic management. And also, of course, in future, in IBD endoscopy, we should have something right on that future of endoscopy in IBD. And we should also mention that image enhancing endoscopy has some role. And artificial intelligence coming in a big way for diagnosis of IBD, even in the endoscopy itself. And future of endoscopic therapy. This is just to show you an ultrasound, show an ulcerative colitis, a malignant polyp. And we can see the narrowband imaging. And here there is an area with loss of pattern totally. And this is the biopsy, and this is the endocytoscopy. And it shows that area of adenoma, another area of carcinoma. This is an ulcerative colitis. This is the histopathology. And this is the endocytoscopy. And these are the crypts with totally lost, crypts with total loss, and here crypts with multiple inflammatory lesions there. This is the comparative histopathology there. And the future of endoscopy, probably that even drug delivery can occur with IBD therapy, especially for biologics, etc., or in the region of stricture where you can actually implant certain things, medication which. So why you need an Indian consensus? So let us look at the Indian scenario. IBD is emerging as a major health problem in India, we know that. There is necessity for enhancement of Indian data in IBD endoscopy. In all areas of IBD, of course. And also there could be possible, we actually basically depend upon Western or outside India data available for our patients. And we know that there could be phenotypic variations in Indian population. We know that the genetic studies show that the genetic changes are different in Indian patients. And also we don't have any good practicing regulations for IBD endoscopy. And we know that endoscopy is a very important area for making a diagnosis of IBD. Still we don't have many recommendations or classes on endoscopy IBD. And when you choose a therapy, it's very important that because of limited resources, if you choose a costly therapy, you need to know that this is going to be likely to benefit, so that all sort of resources or all sort of investigation should be made available, at least should be utilized to the best to make a possible prediction of treatment. And also you should make availability of practice of quality endoscopy in our country. And this has to be done only by making awareness of these areas, especially IBD endoscopy. And when you practice the target to treat, there is inadequate knowledge about, unless we know that these are present, and you cannot actually, we have seen it is healed, that is mucosal healing. So I think this also has to be defined better. There are available literature on that, of course. Then IBD endotherapy is not tapped properly in India. So why this is important for us? Because we know that we are in the phase of an aggressive phase of IBD in our country. We look at the epidemiological classification all over the world. We are actually in the aggressive phase. India is in the aggressive phase, so it is very important. So why we need an Indian consensus? First of all, we need a uniformity in diagnosis. When somebody from north talks to me to south, or from one center to another, we should know what this doctor is communicating to me or trying to communicate with me. So there should be uniformity. And differentiation of IBD mimickers. That is very important. Still, it's a big problem. We always, now of course I agree that the chances of writing an empirical therapy for tuberculosis is very, very less now. But of course, still it is a problem, at least in certain parts of the country. And assessment of prognostication and activity assessment, identification of high-risk cases. We can actually utilize these resources better by giving biological therapy, etc. And also define treatment options in our situations. And there should be a consistent follow-up endoscopy, when to do, what type of endoscopy, full-length colonoscopy or small bowel assessment, etc. Suppose we have seen only a capsule endoscopy has shown a lesion. And how we will follow up that patient? We have listened that in capsule endoscopy, we picked up early Crohn's disease. And you want to assess how the patient has improved. Will you do a capsule endoscopy again? So these are all the questions need to be answered. And also, I think, very important thing, which I have seen many times happening with surgeons, that they think surgery is the end of treatment of IBD. But no, we're not in Crohn's disease unless if you treat the patient properly, or even ulcerative colitis, we have seen patient coming with pouchitis, all other complications. And pregnancy and IBD, it's a specialist approach is required. We need to be aware, educated better. And also there should be a recommendation on Indian protocols in screening and surveillance of IBD patients, and how long and what sort of technique you want to identify these lesions. And imaging enhancing endoscopy and optical histology and IBD endoscopy. But what I think, chroma endoscopy is not practical everywhere. But I think digital chroma endoscopy is very easily available. And since it is almost equal, I think that should be highlighted in our guideline, because chroma endoscopy is not freely available, cumbersome, difficult, and takes more time. But of course, in high volume centers, people are doing it routinely, it's fine. And also, you have to standardize therapeutic endoscopy. What I have seen is whenever something new comes, everybody will jump on to do that. But I think we should have a strict guideline, what could be done, what cannot be done. And also, we need to draw more data from India for endoscopy in IBD, especially what I believe focused on endoscopy in IBD. There should be a beginning and they should go on. And also, we should include other countries, emerging nations where the IBD is increasing in number. This is very important. So coming back, again, we have come to a consensus, and I think that is the beginning, and it should be excellent because we used the consensus because guidelines is not easy. So thank you so much for your kind listen.
It was an excellent job. I thought at the end of this full-day discussion, nothing was left. But Matthew, you've done a full justice to the subject given to you. I didn't even know that what you will speak on. Excellent. Thank you very much for putting the things in the right perspective. Any comments? Any comments, questions? Before we conclude this meeting. We are already past 6 minutes.
Regarding endoscopic ultrasound, whether it can be used to see the vascularity of the lesion, to where to perform stricturotomy, whether it will be useful?
What you do is you have to do a mini probe. There is no vascularity assessment on that. So I think for that you need I'll tell you what I have done. I had a patient with a rectal stricture. So I used a forward viewing echo endoscope. And that helped me. This is only an experimental on that. My treatment did not decide upon that. But I use EOS very frequently in...
He has made it sitting here since morning. That's a real commendable. Real commendable.
No, I tell you, I have actually deleted all my presentation. This is all made now.
No, it's so obvious. It is so obvious. That's the reason it's so relevant. Because you have made it here. And that's the reason it's relevant. It's a real commendable. I'm just complimenting you on that.
Transperineal ultrasound, UL, can be used for assessing the disease activity, rectal thickness.
So I think that last time in the meeting on the perianal fistula, we did discuss the role of endoscopic ultrasound. Probably that's the only area where it will be relevant.
Biologics, thousands of articles will come.
This is not a problem unique to us.
And one more thing which I wanted to discuss, and even surgeons have operated for gastric obstruction, later turned out to be Crohn's disease, that we have seen. And ulceration, a young patient, multiple ulcers, deformed pylorus, duodenal showing ulcers, and I think, we are generally taught not to take biopsy from D1. But, in this type of situation, I have taken biopsy from D1 and I have seen granuloma also. I think, upper GI Crohn's to be defined better, this form.
Circulate a neat set of statements, all statements together for everybody's edits. Just no literature, no nothing, what we have discussed. Once that is kind of ready, together with the level of recommendation. I think Dr. Vishal and Dr. Partha have already done some work on that. We'll take a call.
I think we come to the end of the meeting, and it's a real privilege having all of you here for the whole day. We went through a lot of things, and hopefully some of this will get concretized paper. Hopefully will come through. I think you should give deadlines. That's right. In 3 months you should have the draft. So this evening, 8:30, we're having dinner here, just outside. Hopefully don't rain. And some of you, I think, are going out and hopefully coming back by that time. Oh, okay. No, you can get it now also. You don't have to wait till 7:30. Okay. Okay. So thank you. Thank you. Again, I like to especially thank Satyanarayana. In fact, Satya single-handedly did everything. It's not very easy to organize something in this hotel here. So single-handedly.